presenting a new series Medically Verbal where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 4: Chief Complaint. A 68-year-old male presents to the clinic with progressive shortness of breath and a persistent cough. History of present illness includes the breath gradually worsening over the past 3 months. He's suffering from chronic cough and it's worse in the mornings. Produces small amount of white sputum with no blood in it. He doesn't have any chest pain or fever. He's tired and has noticed swelling in the ankle over the past 2 weeks. Past medical history includes COPD, chronic obstructive pulmonary disease, hypertension, hyperlipidemia. He's currently on albuterol, lisinopril, atorvastatin. His social history includes him smoking a pack of cigarettes per day for 45 years. He quit 5 years ago. He drinks alcohol socially and used to work at a construction site. Family history: father had coronary artery disease and mother had type 2 diabetes. His physical examination shows BP 130 systolic, 85 diastolic, heart rate 88 beats per minute, respiratory rate 22 per minute. Temperature is 98.2 degrees Fahrenheit. His SpO2 is 92% on room air. His respiration region shows decreased breath sounds bilaterally, scattered wheezes, and he has a prolonged expiratory phase, which means he is taking way long to release the air. His cardiovascular region shows regular rhythm, no murmurs but jugular venous distension. He has a soft, non-tender abdomen with no organomegaly. He has a bilateral pitting edema up to mid-chin in his extremities. Initial differential diagnosis: COPD exacerbation, congestive heart failure, pulmonary embolism, chronic bronchitis. What do you think it is, and what could be the next steps taken for it? 5, 4, 3, 2, 1. So this one's a bit tricky actually. If you're feeling something between COPD exacerbation and congestive heart failure, you might be on the right track because the patient already has a history of COPD, and at the same time his risk factors of smoking does accumulate towards it. For congestive heart failure, there is jugular venous distension, which is pointing in that direction as well. Regarding the other diagnoses like pulmonary embolism, because there was no chest pain or any sort of blood in the sputum itself, it's less likely to occur, and of course there was no history of thromboembolism, so that is also ruled out. For chronic bronchitis, it could be a part of the COPD itself. For investigations, we would ask for spirometry to check out his lung volume to see how much the airflow is actually limited. We'll do a chest X-ray to check for the signs of heart failure like cardiomegaly, pulmonary congestion, or any sort of lung pathology. We'll perform an ECG to see any sort of elevations or pathologies to rule that out. An echocardiogram would be done to assess the cardiac function and to look for evidence of the cardiac failure. We'll do a blood test, CBC-Y, to see whether the white blood cells have increased in case of an infection, or just in case the red blood cells might have decreased, like anemia. And we'll do a brain natriuretic peptide test. So basically this is something which is elevated in case of heart failure. Okay. Basal metabolic panel would be done to evaluate renal function and electrolytes. Why are we doing this? Because if the person might be suffering from heart failure, heart has a function to release ANP. Now if ANP is not released, there would be renal dysregulations in case of releasing or excreting the urine out. So in that case, we will do a renal evaluation of function and electrolytes. For the management steps, we would prescribe the person to take bronchodilators, like he's currently on albuterol. We will ask them to take corticosteroids like prednisone so that the inflammation would be reduced. And just in case if there is any bacterial infection, accordingly we will prescribe him with antibiotics. For congestive heart failure, like I said, we should give him diuretics like furosemide to reduce the fluid overload, of course. And ACE inhibitors would be given to manage the blood pressure and reduce cardiac workload, like he is currently on lisinopril. And oxygen therapy would be given because if the SpO2 is persistently low, then we would provide them with it. Regular follow-up would be done for the treatment to adjust it accordingly, and lifestyle modification would severely advised in this case. Thanks for watching, guys. I love to hear your thoughts and approaches, so please share your opinions and solutions in the comment below. And let me know if you need any specific case history coming up. And I'll try to include those as well in the future videos. Directions or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.